Hello and welcome to Health Styles. I'm Connie Mead. When we think of February, several things come to mind. A shortened month of winter, February school vacation. There are also many milestone days. We have Groundhog Day and President's Day, and of course Valentine's Day. And it's probably Valentine's Day with all of its hearts that is the reason February has been designated as National Heart Month. And so with this in mind, we turn our attention to our hearts and heart disease and our heart health and learn what we can do to stay heart healthy. Joining me for our discussion today, I'd like to welcome two guests to the program. The first is Dr. Omar Ali, let me get that right, who is a board-certified cardiologist at Lowell General Hospital. Dr. Ali practices both interventional and invasive cardiology. Okay, and is also a member of Merrimack Valley Cardiology Associates in North Chelmsford. Dr. Ali is also a physician liaison to the Therapeutic Hypothermic Program at Lowell General.
I am.
Okay, so there you go. So welcome, Dr. Ali.
Thank you, Connie.
And also we have Kathleen LaFerrier, who is a registered nurse, also with expertise in cardiology. And she has worked in the cardiac catheterization lab for many years and is a cardiac nurse educator over at Lowell General as well. So thank you for coming, Kathleen.
Thanks for having us.
Okay, now you have been on the program before, so I'd like to welcome you back. And
Thanks for having me back.
Okay, great. So anyway, so today we're going to talk about our hearts and staying heart healthy. That's the plan. But before we get to that, I want to ask Dr. Ali a question about his specialty because, as I said, you practice interventional and invasive cardiology. Can you just, I think I understand what that means, but just in case some viewers have
As cardiologists, we deal with the spectrum of heart disease, which involves the heart muscle, electrical system, and so on and so forth. Coronary artery disease is probably the focus of what we'll talk about today.
Okay.
And that, in fact, the heart is the bystander. It's the arteries to the heart. It's a disease of what we call the endothelium, the lining of the arteries to the heart. Invasive cardiologists, we offer a test, and so in a sense, we're doing a test for our colleagues to determine who has disease and how much. Interventional cardiology allows us to fix the problem, so to speak, whether that's a chronic problem or an acute problem or an emergent problem, which is often the case, as it was many times this week. So that's the distinction with invasive cardiology is looking at arteries directly and doing other things in a non-surgical way, but in an invasive way, in an X-ray suite that we work in.
Okay.
And interventional cardiology is then taking that data and looking at those arteries and dealing with them, again, non-surgically, but through the wrist or the groin.
Okay.
And that's it in a nutshell.
Okay. All right. So if I am a patient and my primary care physician says, I think you need to see a cardiologist, and maybe it's up to me, maybe the doctor will tell me who to go see, but do I need to know about this distinction in cardiologists? Are there some cardiologists who don't do all of this?
Absolutely not. I think you if you trust your doc and you like your doc and you have a good rapport, go to who he or she sends you to.
Okay.
Because we're all trained in cardiology, and coronary disease, it's in keeping with the fact that I'm in the cath lab a lot, so I think a lot about coronary arteries, perhaps more than a cardiologist who thinks more about the electrical system. But no, you should see whom your doctor trusts and has a relationship with,
okay.
And they then can direct you, if need be, to an invasive cardiologist.
Okay. So, all right. So the patient doesn't have to worry about that distinction. Okay. So that's kind of what I was getting at mainly. So it's all right.
Just
so
forge a good relationship with your internist. That's the key.
Okay. Well, that's all right. We'll do that in any case. All right, so that's step one. All right, so now let's talk about heart disease, because you kind of alluded to it there a bit. It's, when we think of heart disease, many of us, we think of, the heart attack kind of event, but there's more to it than that, certainly.
There is, in fact, and I think that there's sometimes disconnect with patients. Patients are becoming more and more informed, and so one of my colleagues, he and I were chatting about it this week. He thinks of us often as doctors, not of the heart, but of the endothelium, which is the arteries, the layer of, the innermost layer of an artery, whether that's the heart or the leg or the carotid, is vulnerable. It's vulnerable to disruption, plaque buildup, cholesterol has a role, and those arteries can, in simplistic terms, get clogged. So the heart's the bystander. As it relates to heart attack, it's not a primary disease of the heart, it's of the arteries.
Okay.
So what probably some of the focus of our discussion today will be just that, how to address the arteries and protect ourselves in a sense, and take measures to prevent our arteries from destabilizing, rather than our heart itself. Not to minimize the heart, because there are many diseases of the heart and the electrical system, and from congenital to early in life to later in life. But Heart Month is Heart Month, but I think more than anything else, we think about sudden cardiac death and heart attack and acute chest pain in an unstable process. And that is, in fact, a process that's occurring primarily at the level of this endothelium, this layer of cells inside these blood vessels. And that can relate to stroke as well, heart attack, stroke.
Right, okay. All right, so it's not we call it heart disease, but it's maybe it's what's happening before.
Correct. Yeah.
Everything gets to the heart.
Exactly. It's the arteries that lead. And however God made the arteries sit on the heart, and they're very vulnerable. The heart pumps blood, and these arteries can develop plaque. And based on blood pressure, and some of it's physics and where the blood is hitting them. So it's the arteries that's our focus. In the cath lab, it's the arteries, the medications we give, our measures, what we're doing. We're trying to get arteries open and then stable.
Okay. So now let's just get a picture of what heart disease, where we are with heart disease in our country right now. It's still, actually, let me hold off on that. I see that we have a graphic up here that kind of talks about what we were just talking about. So do you want to explain?
Sure, I'd like to. I think up top is a normal artery. And the endothelium, which we spoke about, is just, it's not distinguished on the picture, but it's basically the lining of the artery. The photograph just below is deposition of plaque. That's not normal. You're not born with it. Some people are more predisposed to it. And we see a lot of yellow there, and we think of cholesterol. So there's cholesterol in there, there's inflammatory cells, there's sort of a variety of different factors and cells in there. But it's stable plaque at that point. You can see blood cells passing through it, or around it, I should say. Then it gets disrupted. And this is a heart attack, and this is an acute event that you hope that your body can overcome, which is to say we have our own endogenous, our body makes blood thinners, some of us take aspirin, some of us take atorvastatin or drugs to prevent that plaque destabilization that's depicted in the bottom picture. Because when it destabilizes, then all hell can break loose. I mean, that's a closed artery, and if it happens acutely, lack of blood flow, on the other side of that artery is a wall of the heart.
Okay, let me just ask a question about that middle graphic there, the middle artery, if you will. It looks like the plaque is encapsulated. It looks like it's covered up and it's like part of that lining. Or
it is.
So is that, because when I hear plaque in the arteries, I'm always thinking you have the lining and then the plaque is sitting on top of it, and it gets loose or something.
That's exactly it. I mean, that's a good observation, and I think they depicted it that intentionally like that. So that's a layer of cells, and frankly, the thinner it is, the more vulnerable that particular plaque is to being disrupted. So it's not so much how big the plaque is. You can see that's a sizable plaque. That's a patient. That artery, that plaque, that could be an asymptomatic patient who has neither day-to-day symptoms, nor is even at a heightened risk just having that. There's a lot of that out there in the Merrimack Valley, a lot of plaque. And that lining is what can be disrupted by tobacco or stress or toxins or blood pressure surges or adrenaline. And once it's disrupted, depending how thin it is, and we call it thin cap fibroathoma, and we're talking microns, very small, then you set up a situation where once it's exposed, the plaque underneath that lining, that exposure is the trigger for closure. If you, in simplistic terms, if you cut your finger and it clots, that's good. If you cut the inside of an artery and it starts to clot, and some of it's clotting and some of it's other issues, that's not good. And it's the body's response to a pathological process, and it can close off the artery. And then it becomes, there's other things that can govern how bad your heart attack is or whether you'll feel your heart attack or not. But that's associated, that process is associated with emergency situations, heart stopping, arrests, heart attacks.
And so you say there's a lot of people in the Merrimack Valley walking around with this kind of, would you call it a time bomb?
Well, no, I avoid using that term. I mean,
Okay.
I think we're all time bombs, frankly, in every respect. But I'll say there's a lot of folks walking around with a lot of plaque that they're somewhat aware of or not at all. For me, and heart disease often surfaces in two forms. One is you're not right with activity and you get heaviness in the chest or whatever the symptoms that we may or may not discuss, and you call your doctor and he or she then refers you and you do a stress test. And that's good in a way because you can get into the fold, get a diagnosis made, and start taking preventive measures to prevent the more ominous way of presenting, which is to say you're fine, you're okay. You're on a soccer field, for instance, just as an example, someone this weekend, and a plaque destabilizes. You don't have a problem. Now it destabilizes. You're at risk, perhaps from uncontrolled blood pressure or cholesterol. So I think that a lot of us have plaque, and then the focus becomes on keeping it stable, preventing progression, so that we don't need then to get a balloon or a stent or a surgery or all these things. Preventing progression, but preventing destabilization and having that bad day. When Monday was a good day, and here you are on Wednesday, and how did this happen? So the plaque, and you had pointed out that cap, and yes, indeed, thin caps with active oxidized lipids, cholesterol, are more at risk. And smokers have them, and people who are diabetic have them, and people with genetic predisposition have them. So I think that who then should be brought into the fold and more aggressively dealt with is something that our primary care physicians deal with every day. And who's at what risk? Who should be on aspirin or not, or Lipitor or not? I think smoking's the easy one in 2014.
Right.
You shouldn't do it.
Right. And blood pressure is another key factor, correct?
Very much so.
So can you explain the blood pressure thing? Because I think the smoking, that weakens your vessels. Is that what happens with the smoking?
Yes, or causes plaque, both processes,
Okay.
plaque progression and plaque destabilization.
Okay.
Like I passed my stress test on Monday and I feel great because I have a lot of plaques like the middle picture. And then you smoke a cigarette on Friday and disrupt one of those plaques and have a heart attack. How's this possible? You took a plaque that wasn't that bad and closed it. And so I think that that smoking, the blood pressure causes wear and tear on arteries, for lack of a better term. And sometimes heart attacks occur in the year or two when your blood pressure gets a little out of control. It's been stable, and then you need more medications, or life circumstances become more stressful, or whatever external factors there are, and your blood pressure is more of an issue. And you have the heart attack, you get through it, and you know what, doc? It turns out my blood pressure was 140 over 95 a lot this year, and it had been 120 over 80. But we think that's as simple as physics. It's higher pressures. If your resting blood pressure is higher than when you exert yourself on a soccer field or snow shoveling, it gets up there, and it predisposes you to that acute rupture.
Okay.
That's the blood pressure piece.
Okay. So, and we're all at risk for this, you say, or certain people are at risk.
Some at more than others.
Okay.
The more risk factors you have. So the lining of the artery that Dr. Ali was talking about, that's a lining of protection, and things weaken it. So it's the smoking, it's the high blood pressure, it's the diabetes. So all that extra sugar floating around weakens that lining as well. And then as the lining gets weakened, it sets you up for heart disease. And then, again, it could be a plaque rupture as well, depending on what the circumstances are going on. So the more risk factors you have, the more you're actually weakening that lining. Being overweight, especially being overweight with belly fat, not exercising, these are all things that actually weaken the lining of the artery. And that's our protection. And it's, we're all at risk.
I like Kathy's word, lining, because it's a basic term and it's almost a lay term. Lining of arteries, protect your lining. And I get patients to sort of buy into their endothelium or lining after the fact. Up front, I'm not seeing patients who have heart disease usually. Preventatively, that's not the nature of the specialty, but the lining is something that patients and doctors, physicians should think about. I'm giving you a torvastatin or a statin or a Lipitor to protect your lining. I'm not giving it to lower your cholesterol. Oh, I'm doing that as well. Lining.
Okay.
So I like that.
Okay, so maybe Kathy, can you tell us what we can do to prevent, the buildup of some of this plaque in our arteries? Is there anything any proactive measures we can take?
Well, the biggest one is not to smoke. So that's the number one preventable cause of death in the United States. And actually, the second preventable cause is actually obesity. So it's weight and exercise. Those are two things that everybody can do. And then the other thing is you need to follow up with your doctor to get your blood pressure measured, to get your cholesterol measured, to find out if you have diabetes. And then, heart-healthy diets, mostly fruits and vegetables and fish, lean meats, the olive oil, stay away from fried foods, stay away from, white rice, the white breads, go more with the whole grain stuff. I mean, it's out there. I think everybody has the education. It's more of implementing it. It's hard.
Right.
It's easier to eat bad than it is to eat good.
Right. And if you have a bad habit, it's hard to break that bad habit. Yes.
It really is. Yeah.
Yeah. Okay. So, so do people get more or develop more risk as they get older, just because it's a cumulative effect? I'm assuming. Correct?
Absolutely. Aging is one of the non-controllable risk factors. Kathy alluded to some of the controllable ones. Aging and male sex, to an extent, are things that work against you with genetics. So the older we get, now there are octogenarians and 90-year-olds who don't have plaque, but it's certainly a risk factor. So we as physicians, when we're screening people or evaluating someone in the emergency room or the office, age is one of the things we look at, and the paramedics as well. We're trying to gauge who has what. Unfortunately, young people and women as well with uncontrolled risk factors can have events at a fairly young age, and we see it. And so it's not an absolute that you're protected because you're premenopausal as a female.
Right.
Or I smoke but I'm 28. Can happen.
Okay. Well, especially we hear more about the obesity problem. I guess we're starting to get a handle on that in our country. At least I think the numbers are getting a little better, aren't they?
I don't think
not
so.
Necessarily. Okay. All right. So
No, not yet.
especially with younger people, this is an issue. So this predisposes them right there.
Yes, it does.
I think it gets to what you said about bad habits.
Yeah.
I think that they do start early, and you're right. Diabetes, I don't, any more than I want to use the word time bomb, epidemic. I mean, diabetes is becoming far more common later in life, and I think you're aware of that. And it has a lot to do with being sedentary, but developing awful dietary habits at a young age. Potentially modifiable.
And the problem with kids being overweight at a young age, it sets them up for disease processes that used to be reserved for middle age, so the high blood pressure and the diabetes. Kids are getting this now at much younger ages, so this is going to set them up for shortened lifespans.
Okay. Yeah, I think I've heard that it said that sometimes they think that this next generation or the generations to come may not live as long as their parents, whereas we have been used to outliving our parents.
So a lot of the improvements, mortality is the word we use, dying from heart disease. Mortality rates have improved in a lot of ways because heightened awareness and people learning CPR and catheterization labs that open arteries quickly and technology. but what you're right, what we're going to see in the decades to come is we've sort of reached, I want a plateau, if you will, in some of the other therapies that have advanced. And we have a lot of concern that that particular piece, the poor lifestyle, obesity, eating of consumption of food that's atherogenic, causes plaque, and diabetes, it's going to result in a lot more plaque, a lot more disease. Sort of take back some of what we gained in the last 2 decades.
Okay, so let me just think now. Maybe you could just kind of make it real for us, so people who maybe haven't seen someone suffer from heart disease or have a heart attack or a heart event, can you tell what the rest of us, let's say, what their life is like after a heart event? How has it changed? I mean, I'm trying to give people incentive, if you will, to take to heart some of the recommendations.
No, and I mean, you can speak to that as well, Kathy. I think that, unfortunately, in my line of work, when I get a patient, they're on the other side, and I can lean on them, and they don't have as much defense. They've had it. They've gotten a little lucky. Internists have a very, very difficult job. You know, it's not enough to say your dad died of a heart attack at 45. You know, watch your weight, stop smoking, take a statin. You know, statins in particular, and you know, this is not to promote a particular drug, but statins save lives. They stabilize this plaque, and they do that. Who on earth would take one? I mean, you know, you take medicine for a reason. You know, you're coughing, I give you Z-Pak, you'll feel better. And if and you only have to take it for 3 days. And if you have heartburn, I'll give you Zantac or Pepcid or Prilosec. And you know, you'll feel better and you take it, and you can take it and stop taking it. How about you take this Lipitor, but not for 3 days or a week, but for 40 years? And oh, by the way, it won't make you feel better. It might actually make you feel worse. I mean, there's this possibility. You're signing on for a lot, and there has to be a trust there. And so I think that, you know, I think the people who, the physicians who will have the hardest time in terms of motivation and life alteration are the internists at the front line, if people don't have the disease yet. Because it's this abstract thing that may or may not have. You know, I smoked yesterday and I was fine.
Right, right.
And look at Keith Richards. He's never had a heart attack. He's this, you know,
Yeah.
and there's people with this miscreant lifestyle who've never had the problem. So, on the other side, you know, we have outstanding cardiac rehab program locally, and we feel like, you know, and not universally, but in general, you can get people to buy into a healthier lifestyle, a non-perfect lifestyle, but healthier than what they had in advance. And take basic therapy, basic medications. There's not that many plaque drugs, actually.
Okay, okay. Okay, let me just ask, since we're talking a little bit about the future and the younger generation, is there any hope in terms of some of the new technologies that are coming out, or genetic research, stem cell research? Is that going to impact heart disease and how it's treated?
I think it'll probably impact both sides. You know, the genetic piece will probably impact the way we screen patients. You know, right now you screen patients by checking their blood pressure and cholesterol. And that's about it. You know, and you pay attention to their genetics and cholesterol. There's not a myriad or a battery of 20 blood tests. There's a lot of surrogate markers of ultrasounds and CAT scans, but they're not conventional. So it may help there. I think the stem cell piece is unfortunately something that's not progressed the way we had hoped. We used to think of the heart as myocytes, heart cells. They die and they don't come back. Turns out that's not the case. They do regenerate to an extent, and implantation of cells into the heart could do that. That's actually an exciting area for people who've had the heart attack, survived it, and have weak hearts to improve their heart function. So I think that's the role of stem cells on that front. But aside, you know, we're looking for plaque modification therapy. You know, we're looking, you know, if there was a therapy, ideally natural, which you could take or infuse that would stabilize all the arteries, that would be ideal. And, you know, and there are people looking at that in different places. Of course, when that finally happens, it'll probably shut down the liver. That's usually the way medicine works.
Okay.
But that's there's nothing imminent on the horizon that's going to stabilize plaque preventatively. We're getting things all the time for our cath lab, you know, in terms of acute, someone's having a bad day. You get him off the table alive with his heart, and every day we have more. That's what's exciting. Our ability to deliver acute care at a high level, and so the field is advancing there. And some of that's driven by industry, frankly.
Okay. So for us who are trying to stay heart healthy, so what should we be doing? You mentioned the exercise, the diet.
Exercise at least 30 minutes a day.
Okay.
We know people who exercise or walk the dog 30 minutes a day actually are healthier. People who don't exercise. So some type of exercise, usually something, you know, cardiovascular, where you're getting the heart rate up, aerobic. So you want to brisk walk.
Right.
30 minutes every day.
She says it like 3, but she meant 30.
30 minutes, 30 right.
Minutes.
30
Did I
minutes.
say 3?
No, you said
No,
30.
Oh,
but
30.
Yeah, we just wanted to.
30 minutes, and then the diet is the other thing. The diet is key. You know, these fast food restaurants, they're killing us. And
well, just between portion size and the ingredients and
the high fat, high salt, and the high sugar content in the food. And then when you have all that in the food, doesn't have the nutritional value either. So it's back to basics. It's the Mediterranean diet, or there's a diet called the DASH diet, dietary approach to stop hypertension. They're very similar, and it's mostly fruits and vegetables and lean meats and olive oils and walnuts and all the heart healthy stuff. And, you know, we know that people who have mostly a plant-based diet, you know, have healthier arteries, you know. So
absolutely
something to be said for that, but it's hard in our in society to do that.
You know, she mentioned fast food, and having a job, just as an example, whereby you're mobile. I mean, moving all day. You think of the hunter-gatherers from prehistoric day; they were moving all day, and they died from other things, probably like woolly mammoths or what have you. They had their own stresses.
Infection.
Right.
There you have it. And so, but you know, I think about a fast food restaurant is when you look at it from the sidelines, you don't have to move to get your food. It gets brought to you, and it's high in sodium and high in trans fats, and if not trans, saturated fats. They're atherogenic. They're highly caloric, and I'm not suggesting we go back, turn back time, but I worry a lot about my patients the year they retire. Just as an example, they get sedentary, and then they, and it's even if the dietary part is reasonable. So keep moving and pay attention to what you're eating. Stay educated, informed, and you have your doctor as a resource. You have the internet as a resource. So
I've heard one movement towards the standing desk is one way they're trying to keep people from being sedentary. Do you have any thoughts about that?
Standing or sitting on the ball?
Well, I've heard of sitting on the ball too.
Yeah.
But I thought that was mostly for kind of physical toning.
Yeah.
But is that good from a heart health?
Well, it's good it is just good for your toning and keeping your core, strong when you're sitting on the ball at the desk. There's one physician in our area has a treadmill at his desk, and that's what he does,
Right. So it's that sort of thing. Is standing at your desk. I think I've heard the quote, sitting is the new smoking. If you sit all the time. I don't know if, so that's, too much sedentary lifestyle can,
I mean, I know if you have
damage.
a desk job, they encourage you get up, at least once an hour and, move around for a few minutes. Or if you can't find 30 minutes into your day to exercise, you can do 3 10-minute, bursts of, exercise, something to move.
Okay. So let me just ask, so after we've talked about all this plaque that we have and, we want to keep that layer stable and we want to keep it from destabilizing, can we effectively lower and get rid of that plaque that's already there? Or once it's there, is it just a matter of kind of not letting it get worse?
we get this question from patients all the time.
Okay.
Right, and particularly engineers. There's plaque in me, and I want it out. And I think there's very few therapies that have been proven to actually reduce plaque. There's some therapies that have been proven to modify from destabilization or prevent progression. High dose statins can do it. However, it's microscopic. We don't even know what that means. If you have this much plaque and you can shrink it to this over 20 years, does that mean anything? Is it still, does it destabilize? So I think that, this concept of actually dissolving it, coronary disease, this plaque disease, is such a diffuse process. The heart attack is the artery, the plaque that closes, but once you've opened it, you're left with diffuse plaque everywhere, and you're not going to get rid of it. And a colleague of mine will often make a point of telling every patient, there's no cure for this disease. You can't get rid of it. And even if you could shrink it a little, so what? Just prevent progression, prevent destabilization, and you'll be in good shape. And if you go to the grave 40 years from now, you get hit by a bus and someone opens you up and you have the same plaque you had in 2004, you win. And that's kind of our approach. Now, will that change? I don't know. I don't think it'll change in my lifetime.
Okay.
I don't.
Okay. All right. I know we're running short of time. I just want to ask Kathy a couple of questions about programs coming up. I think we're down to almost our last minute. You do have a few things set up during the month?
We have, March 1st, we have our Heart Healthy Fair, and that's free. That's going to be up at Low General at the main campus, and we will be doing cholesterol screenings, diabetes screenings, blood pressure, body fat analysis, and we can kind of give people what their risks are of having a heart attack or stroke. And then along with that, there's going to be a lot of education pieces there too. So that's open to everybody, and that'll be 8 to noontime at the main campus.
Okay.
If you want your cholesterol checked, though, we ask that you register ahead of time because you need certain slots, and it's a 10-hour fast.
Okay.
Other than that, people can just show up if they don't want a cholesterol
And was there a
screening.
cost for that? Did you
No,
say?
everything's free.
Oh, okay.
It's all free.
Excellent. All right, thank you.
And it's a full cholesterol panel, too. It's not just the one number. It's the HDL and the LDL and the triglycerides as well. So.
Okay. Well, I think we'll have to leave it at that. I know we're just
Okay.
about out of time. We've put up the Lowell General website, so you can go to that to register for the cholesterol panel and other parts of the program. And they have many other programs coming up during the month, so check that out. And check our message board too, because we'll have them listed there as well. So I want to thank you both for being here today. I've learned a lot.
Having us.
Okay, a lot of things I got to get
Wednesday.
working on. Yes.
Yes.
And I want to thank you for being here as well with us today. Thank you.